Hello, welcome to Wellness and Wisdom with Dr. Nadu Tuakli, the podcast dedicated to empowering women over 40 to age gracefully, competently, and beautifully. I'm Dr. Nadu Tuakli, a family doctor, preventive medicine specialist, author, teacher, mother, and expert in hormone replacement, anti-aging, and longevity. With decades of experience as a physician and as a woman embracing every stage of life, I'm here to share practical advice, expert insights, and inspiring stories to help you thrive in happiness, health, and appearance. Together with my guests, we'll explore topics that matter most to you, from navigating perimenopause and optimizing your health to redefining success in retirement and beyond. Let's celebrate the aging process with vitality and purpose, because your best years are still ahead. Subscribe now to add more life to your years and step into the best version of yourself. Welcome to Wellness and Wisdom. I'm your host, Dr. Nadu Tuakli, your trusted guide to living well at every stage of life. Today, we're diving into a painful subject. Yes, pun intended, because we're talking about pain. Deep, long-lasting pain, the kind that no one seems to be able to explain, the kind that lingers, frustrates, and doesn't respond to the usual treatments. If I sound energized, it's because I'm the type of person who likes to get to the root of a problem, especially when it comes to helping my patients find real answers and lasting relief. Whether it's aching joints, nerve pain, past injuries, or pain without a clear cause. So many people feel trapped in a cycle of discomfort, confusion, dependence on medications that often don't help in the long run. But what if there's a better way? If you or someone you love has ever struggled with chronic pain, today's episode is for you. My guest, Dr. Shana Johnson, is a board-certified specialist in physical medicine and rehabilitation, with over 2 decades of experience helping people break free from the cycle of pain. She has a deep focus on pain, science, and neuroplasticity, how the brain and body can actually rewire to heal. And she combines medical expertise with real compassion. She's also the voice behind AskDrShana.com, where she educates the public on evidence-based, non-opioid approaches to pain management. Today, Dr. Shana joins me to talk about what pain really is, why it becomes chronic, and most importantly, how to move through it. Whether you're navigating nerve pain, joint stiffness, or frustration, mystery pain, no one seems to understand. This conversation offers real hope and practical tools. Let's explore what pain really is, why it can become chronic, and more importantly, how to break the cycle for good without addicting medications. So let's get started. Welcome, Dr. Shana.
Thank you.
You're welcome. Thank you so much for being here. So let's start with your specialty, because what exactly is a PM&R doctor? And how is your approach to pain different from that of a typical pain specialist?
Yeah, so PM&R stands for Physical Medicine and Rehabilitation, and we are our own medical specialty. And we tend to focus on disorders of the musculoskeletal system and the nervous system, and with a particular focus on conditions that are chronic or long-lasting. And we also focus on pain and chronic pain.
So when people say they're seeing a pain specialist, they usually are not referring to a PM&R person, correct?
Well, that depends. There's a couple of different specialties that focus on pain. A lot of pain management is done by anesthesiologists. However, they tend to have more of a procedural focus. PM&R doctors, we have a more holistic approach. Some of us do procedures, but we really look at the whole person, and our goal is improving function and quality of life. So we have kind of a wider lens and a longer term lens than, say, someone in an anesthesiology clinic.
So can we start by laying the foundation? What is pain really, and why do some people suffer so much more than others?
Yeah, so, pain was evolved as a protective mechanism to tell us that something was wrong and we needed to address it. However, just like any other system in our body, things can go wrong. And chronic pain can develop due to abnormalities that develop in how our nervous system processes pain. And in that way, pain can become chronic and in some ways kind of like its own disorder, because at that point it's not protective anymore.
So can you walk us through the main types of pain, like inflammatory, neuropathic,
Yes,
mechanical?
yes. So this is so important. Understanding your pain type is key to getting the right pain treatment. So not all pain is the same. So the first type of pain is nociceptive pain, and this is pain that arises from inflammation and tissue damage. This is kind of the classic type of pain when you think about pain, like a broken arm or a sprained ankle, and this pain is protective and it's alerting you to take care of that area. The second type of pain is called neuropathic pain. And this type of pain is from direct injury and damage to nerves. So in this case, you might hear people with diabetes have burning pain in their feet from diabetic neuropathy. That is from nerve damage in their feet from the diabetes. Another type of nerve pain might be carpal tunnel syndrome. So that's neuropathic pain. The third type of pain is called nociplastic pain. And this is a pain that arises from abnormal pain processing in the brain, the spinal cord, and the peripheral nerves. And this type of pain is really maladaptive process by the body, where the pain is not protective. It's more of a false alarm, and there's not necessarily any underlying tissue damage. And because of that, it's treated much differently than the first type of pain.
Well, that makes sense, because if it's a false alarm, you would want to treat it differently than if you had inflammation somewhere, which would respond to an anti-inflammatory, correct?
Yes, that's right. So nociceptive pain responds to what I call the peripherally directed therapies. So when we take anti-inflammatory medicines, if we do steroid injections, if we get procedures, those are all focusing on correcting a structural problem and underlying inflammation. Where with neuropathic pain and nociplastic pain, the area that's not functioning correctly is the nerves and the nervous system. So none of those other treatments are appropriate. It's not where the problem is at.
Now, a lot of people ask, is fibromyalgia, for example, is it real? What is the science behind it?
Yes, fibromyalgia is absolutely real. We now know that the most common chronic pain conditions seen in the doctor's office are often driven by the third type of pain called nociplastic pain. And fibromyalgia is one of those conditions. But to show you how broad and encompassing this pain type is, fibromyalgia is one type, and it causes widespread body pain from abnormal pain processing, but also many people with chronic back and neck pain, temporomandibular pain, chronic stomach pain, irritable bowel, chronic bladder pain, chronic pelvic pain, all of these pain disorders, a significant amount of symptoms is driven by the abnormal pain processing from nociplastic pain and not inflammation.
So why do some people continue to experience pain long after an injury, for example, has healed? What's going on there?
Nociplastic pain is often triggered by an acute injury or even acute disease. When the body gets injured, it attempts to heal and there's a lot of inflammation. But in some people, that inflammation doesn't stop and it can actually result in neuroinflammation. And the neuroinflammation disrupts how pain signals are processed and perceived in the brain and spinal cord. And it can create a hypersensitivity, how these pain signals are processed, and can actually start perpetuating the pain, even if the structural injury has resolved. So these changes result in the pain signals being amplified to the point where even normal signals are reported to you as pain. The brain has this natural mechanism to turn down pain levels, and what we see is decreased pain inhibition. And as pain becomes chronic and this maladaptive abnormal pain processing continues, we actually see increased brain connections in brain regions that process pain that are not good. They're maladaptive. And we can see that now on functional MRI, and we see that in fibromyalgia patients as well.
So basically, it ends up being where some people have a lower threshold for pain and some people have a higher threshold. So is that biological, psychological, or both? It sounds like it's biological.
Yeah, that's a great question. So this whole process that happens is biological. However, the risk factors for developing this are also environmental. Because, for example, we know if you're under long-standing, overwhelming stress, that shifts your body into kind of like a chronic stress response state. And that state is more of an inflammatory state in the body and is a risk factor for developing one of these syndromes. In fact, many patients that I've seen developed, I call their nociplastic pain syndrome, their chronic back pain, their chronic headaches, their GI problems, while under a state of huge stress. Another huge environmental factor is a history of early childhood trauma. We don't totally understand why this is, but early data suggest it's due to, again, them being shifted in a chronic survival mode since a young age, predisposing them to developing these syndromes, as well as potentially epigenetic changes. So we do have environmental factors that put someone at increased risk for developing one of these pain conditions.
So what advice do you have for someone who's been told that, quote unquote, there's nothing wrong, but they still feel pain? How do we validate and treat that?
Well, that statement is a huge red flag that there's nociplastic pain. So if that's what a patient is hearing, then it's time to find a provider that understands the spectrum of pain disorders and nociplastic pain and to be evaluated. Because that's what 90% of my patients that come to me say is they told me nothing was wrong. They told me my mild arthritis doesn't explain my disability. I mean, that's what they're told.
So we've talked about pain, what it is, and why it becomes chronic. Let's dig into what we can actually do about it without reaching for opioids. So what are the real alternatives? Does lifestyle or diet have anything to do with chronic pain?
Yes, absolutely. This is such a big topic. I'm trying to think here where to start. So from a lifestyle standpoint, even with chronic pain disorders, we know that the more you're able to move and keep moving, the better you're going to feel. From a nutrition standpoint, it truly applies to all of us that our bodies are healthier and can cope better when we eat a more, whole food, nutritious diet as opposed to an ultra processed food diet. So lifestyle and nutrition certainly go into that. So when we think about treatment for nociplastic pain, it is an entirely different approach than if you have inflammatory pain. And the first thing that I tell, other providers that people with nociplastic pain need to understand they have nociplastic pain. Because if you don't know why your pain levels are this high, it is a natural survival instinct to be fearful. And a lot of these people feel like something horrible is being missed. And this fear can double their pain levels. So step one is educating them what nociplastic pain is, how it's affecting their pain levels, and what their individual triggers are. And also understanding that whereas inflammatory pain is protective, nociplastic pain is a false alarm. It doesn't serve a functional purpose, and it results from abnormal pain processing, and we kind of need to retrain the brain that everything's okay. So that's kind of step one. First, we've educated patients. The second is finding what their individual triggers are. So for some people, it's stress. For some people, it's conflicts, emotions. Other people, it's work. And why is that? Why are there so many triggers that can double your pain level? And why is this important? It's because the brain doesn't process pain. You would think that you get a pain signal, it goes to your brain, it lights up, it tells you you're in pain, but that's actually not how chronic pain is processed. There's actually multiple circuits that feed into what your ultimate pain level is. So you might have an injury or structural damage that tells your brain something. You may have had prior trauma that tells your brain, oh, you might be in a lot of trouble. It's in a hypervigilant state. And as well, mood, depression, anxiety, fear will also dial up that pain level, which is why such a holistic approach is needed. because the brain really looks at all of these things when it's processing pain, and then it reports to you your misery level. So that's one of the reasons why the holistic approach is so important. And then when we get into the role of medical therapies, since the problem is in the nervous system, opioids are actually not a great treatment because there's more specific treatments for problems in the nerves. And so we often, there's a couple of medications that we use that specifically reduce nerve pain levels and hypersensitive nerves, and we use those classes more. We also look more at things like acupuncture because that can also help kind of reset the nervous system. Mindfulness practice is actually shown on functional MRIs to reduce pain level by up to 30% by kind of weakening the connectivity between the experience of pain. Well, it disconnects the pain relay center, the thalamus, from the sense of self, which is the default mode network. And that weaker connectivity reduces the pain you feel. And so we do all of these things, plus trying to find effective medical therapies.
So let me ask you this. In women, does hormone imbalance have any role in pain intolerance?
That's a great question. I haven't read any research on that, but if you're in a perimenopause state and you have different hormones every week and you're not sleeping, it does make everything worse.
Right. In terms of nociplastic pain, is there age difference or does it occur across the age ranges?
It can occur at any age, but we typically see it developing in young adulthood.
And so it's clear that even though we hear so much about opioids, they're not going to be effective in this particular instance, right?
Well, yeah. So when it comes to thinking about opioids, I'm going to dial it back to first step in pain management is understanding your pain type and what strategies work best for that pain type. If you have severe inflammatory pain from an injury, like a broken bone, opioids might make sense in that case. But when you have nociplastic pain from abnormal pain processing, opioids are not the best choice. They don't really work very well either for nociplastic pain. Someone might think they work for a couple of weeks, but then you'll notice they keep wanting a higher dose and a higher dose. And then you check their pain level and it's still 10 out of 10. And not everyone will agree with that. Not all patients, but that's just been my personal experience. When it comes to nociplastic pain, addressing all the pain amplifiers, as well as finding an effective medical therapy for that person is the first line therapies are more medications that target the nervous system, like gabapentin in the one class, amitriptyline or nortriptyline in another class.
Maybe Lyrica?
Lyrica, duloxetine. For people with fibromyalgia, there's some data that low-dose naltrexone may decrease neuroinflammation and help. There's also a lot of research going on in academic medical centers about ketamine, and there's thoughts about psilocybin that help kind of reset the misfiring neural pathways. Some of the newer therapies that are being thought about for this type of chronic pain syndrome are low-dose ketamine, and there's also talks about psilocybin and how their effects may help kind of retrain these neural pathways and reset the misfiring neural pathways.
Now, most of the medications that you have mentioned are not addicting. Is this correct?
Yeah.
And how long can you take them?
With like gabapentin and pregabalin, you can take those lifelong if you really need to. There are some studies that in some people, gabapentin could have a smidgen of, addiction in predisposed individuals, but it's much lower.
Right.
Like in 20 years, I haven't had, anyone develop an addiction or a problem with gabapentin, but there are research papers out there that say it exists. With amitriptyline and nortriptyline, those are medications that you can take for quite a long time as well. There is some data coming out that the anticholinergic medications aren't great for the brain, especially in older individuals over 60 years of age. So I wouldn't say those are lifelong anymore, but there's always like a benefit and risk analysis.
Right.
If it's the
So
key medication for you, you might be willing to take a little bit of risk in that area, especially if you're 25 and it's the medicine that works for you. And then the third class, duloxetine, if you needed to take that long term, you certainly could. And same for low dose naltrexone.
Now, when people are in pain, sometimes movement can feel impossible.
Yeah.
How do you encourage them to begin the physical rehabilitation that is necessary to get themselves out of pain?
Again, dialing back and assuming that it's nociplastic pain that's limiting them and not a structural issue that requires a different approach. There was recently a randomized controlled trial published in JAMA Psychiatry on pain reprocessing therapy. And this treatment protocol kind of helps teach patients how to start moving again. And the essence of it is guided reappraisal of pain sensations while engaging in feared postures and movement. And basically, it's starting low, going slow, and coupling movement with what they call safe signals. So signals that tell your brain you're okay, you don't need to have fear. One of the best exercises to just getting going is just walking. You start out walking 1 block outside in the sun with a friend, having a positive conversation. So you're coupling the movement with safe signals, and bit by bit over time, and by time I mean months, because this is definitely a process that takes time, your brain learns that it's okay and it doesn't need to give you the false alarm. And again, this was shown very effective in a randomized controlled trial.
And a lot of this, too, is the mind-body mechanisms. While we are talking about pain, one thing that I've noticed in clinical practice is our classical pain score. So we score pain on 1 to 10. And it seemed so great when it first came out.
Yeah.
But now I'm not so sure, because one person's 7 is another person's 10. You know what I mean? And I can say to a patient, well, how bad is your pain? And they'll, after they've, told me about their pain, and then they'll say, oh, it's about 8 or 9 out of 10. And I'm looking at this person who's sitting very comfortably in my office. It tells me that this pain occurs every now and then. It really does not seem an 8 or 9. I guess this whole pain score has gotten a little out of whack. It's a little hard to use it. You can monitor the same person, but from one person to another, it seems a little subjective, let's say. I say to patients, when they say, oh, my pain is 10 out of 10, I say, well, that means you have pain that is like the worst you could possibly have. It's making you throw up. You can't move. You can't do anything. And they say, oh, it's not that bad. Well, maybe it's a 7. And I say, anything over 5 is pretty significant.
Yeah.
Oh, no, it's not that bad. I mean, I go to work and, and then now we're down to about 4. Do you have that issue with the pain score?
Yeah. So I think the pain community has really moved away from the pain number, because what matters is how the person's functioning. So we've really moved towards using functional scales. Like for people with chronic back pain, we might use the ODI or Oswestry Disability Index. But yeah, we've really moved to what is your function? I used to joke there's no painometer. So, you ask people what their pain level is, but, in a chronic pain patient, it's not particularly helpful.
Right.
We really focus on, is their depression improving? Are they able to go to work? Are they able to do activities they enjoy? Are they able to spend time with their kids? And also, I think focusing on the pain score can also be the wrong focus.
So what's a common myth about chronic pain that drives you crazy? I'm sure you hear it all the time.
That all pain is the same and it's all treated the same is probably the biggest barrier that I feel like I'm always trying to overcome. Because 90% of the people I see have all been down sent the inflammatory treatment pathway with anti-inflammatories, injections, and procedures for years when they meet all the clinical criteria for nociplastic pain. Once you've had the 5th procedure that doesn't work, time to stop scheduling the 6th. I just had someone who, she's on like her 6th pelvic surgery. She has severe nociplastic pain. She didn't respond to the first 4. They just keep going. And so we need to understand there's different pain types and they respond to different treatments. And if they're not responding to peripherally directed therapies, probably don't have inflammatory pain.
Yeah. The knife is not always the answer.
There is a questionnaire that's been scientifically validated to check for significant symptoms for nociplastic pain called the Central Sensitization Inventory. And if someone with chronic pain, I just offer it as a resource. It's freely available. And, if your score is high, take that to your provider and say, do I have this type of pain instead? And do I need a different treatment? That's how they can kind of self-advocate for themselves. If they feel like they're just in this rut of, getting procedures and not feeling better, that's something they can go to my website. You can take it for free, take the results, bring it to your provider.
Yeah, I was going to ask how patients can become better advocates for themselves, especially when they feel dismissed or stuck in the system. They've got to sort of realize that they need to do something different.
Yeah, I think that's such a great question because I just had someone this week where I would say my number one recommendation is don't be afraid to get a second opinion. Every provider looks at pain a little bit differently based on their training, whether they are trained as anesthesiologists or rehab doctors. We all have things that we know a lot about. We have things we don't know a lot about. So if your needs aren't being met by one provider, get a second opinion. And then, secondly, if you're a chronic pain patient and you're not getting anywhere, not responding to treatments, I would take the central sensitization inventory, see what your score is, bring that to your provider and say, I have a high score. Could I have this pain type? Should my treatment program be relooked at? Because nociplastic pain just got named in 2016, and it's very well known among pain doctors. But most of these patients are seeing their primary care providers, and it's typically not a part of their training.
Now, let me shift gears a little bit. What's your perspective on medical marijuana? Many patients ask about this. I'm always a little hesitant. Is it safe, effective, and how does it help? It's so widely available. I always feel like, okay, if this is going to help the person, why are they even coming to ask me? Because they can get it basically over the counter. But what's your perspective on it?
There's two well-known cannabinoids in the cannabis plant. There's the THC, which is like the psychoactive component, and then there's also cannabidiol. Cannabidiol is not psychoactive. So when it comes to cannabis...
That means it's not going to make you high.
Yeah. Thank
Just
you.
break it down.
Thank you. Cannabidiol, or CBD, in my experience, very helpful for muscle spasms. My neurology population and multiple sclerosis population that I saw in the past, they were all taking CBD at night to calm the muscle spasms in their legs so they could sleep. So I think it's very effective for muscle spasms, can help with nerve pain. It can help with quality of life issues that come up because of chronic pain, like anxiety and sleep difficulty. So I'm a big fan of CBD because it has therapeutic effects and it's not detrimental to brain health. Cannabis with the THC in it, it's not good for your brain over time. We see in studies that if you take high amounts of cannabis over time, there's changes to your white matter and your gray matter that aren't good. So I'm not as big of a fan of the cannabis with the THC.
But the CBD, a lot of people use the oil, I guess.
Yeah, I'm a big fan.
And how is the oil?
I do feel like cannabinoids have gotten a little bit politicized. CBD is pretty gentle and it does have therapeutic properties. It's much safer than the opioids we were giving people for the last 15 years. So I feel like that kind of shows you how much it's gotten politicized. At the end of the day, it's much less risk than the OxyContin that people were on. So I do think it has a place in therapy and chronic pain, I guess, is my opinion.
And how do people take CBD oil?
CBD comes in various forms. CBD drops are very nice because you know exactly the milligrams that you're getting. It's always hard as a physician to know exactly how to recommend the product because we don't have the FDA labeling that kind of gives us all the information that we use to guide patients.
Not trying to put you on the spot here.
Yeah. So That's good for me. So that's always difficult, but I mean, there are instructions on the labeling, and that's kind of where I start.
So is it usually once a day, like just before bed, or do they use it during the day as well?
It totally depends on the person. So some people just take it at night and they'll feel a benefit from CBD for 24 hours. And some people might dose it twice a day. And then, I'd have to look at the specific labeling on the max dosing. But that was one issue I got into with the cannabis. If you're redosing it every 4 hours, that's a lot.
That's a lot. Well, before I let you go, Dr. Shana, tell us about your book, Healing the Pain No One Can Explain.
My book is really about my approach to treating nociplastic pain and the chronic pain disorders driven by this pain type. So chronic back pain, migraines, irritable bowel, and chronic pelvic pain. And it goes through my approach that I call RISE, recognize your pain type, identify your triggers and pain amplifiers, strengthening your mind-body connection so you can manage the pain better, and then finding effective medical therapies for you. And so the book goes through that treatment protocol and goes through many patient stories, people I saw, and how we got from non-functioning to functioning.
Great. Well, Dr. Shana, thank you so much for coming in. I really appreciate your time today and all the information that you have shared. And I will let my listeners know how to get in touch with you if that's okay with you.
Yes, thanks for having me.
You're most welcome. Thank you so much. Thank you for joining us on this important episode of Wellness and Wisdom. If you or someone you love is living with chronic pain, remember, pain is real, but so is hope. Dr. Shana Johnson reminded us that understanding your pain is the first step towards healing, and that true recovery rarely comes from a pill alone. There are real evidence-based tools out there that can help you take control of your pain and your life. So to learn more about Dr. Shana's work, visit AskDrShana.com, where she shares incredible resources on pain science, recovery, and living well without addicting medicines. If this episode resonated with you, subscribe, share it with someone you care about, and leave a review to help others find us. Before we sign off, I want to remind you about my book, Sex, Sanity, and Sleep. This book is for you if someone you love or yourself is going through menopause, perimenopause, or even struggling with PMS. This book breaks the myths, clears the confusion, and helps you take charge of your body and your life. If you're ready to lift the veil on menopause and step into a more energized, empowered you, this is the place to start. Are you ready to feel better? You can find Sex, Sanity, and Sleep on Amazon, Ex Libris, and other major booksellers. Thanks for listening, and as always, take good care of yourself. And until next time, stay curious, stay well, and remember, your body has the power to heal. Bye for now.